This presentation supplements a Stereotactic Radiosurgery for Trigeminal Neuralgia chapter for 8th edition of Humans in Neurological Surgery. I am Adomas Benavides. Typical trigeminal neuralgia is characterized by paroxysmal electric shock-like episodes of neuropathic pain that typically involves one or two branches of a trigeminal nerve. The pain is usually unilateral. The annual incidence rates of typical trigeminal neuralgia is 4 per 100,000. Other types of atypical facial pain can be associated with postherpetic neuralgia, multiple sclerosis, diabetes, or trauma. Medical management is the first-line treatment of trigeminal neuralgia. Other more invasive treatment options include microvascular decompression, rhizotomy, and stereotactic radiosurgery. Trigeminal neuralgia is a devastating and often debilitating disease that is associated with significant impairment in quality of life and level of functioning. The Gamma Knife device was designed by Lars Leksell to perform deep-seated surgeries for pain and psychiatric disorders. And stereotactic radiosurgery has become an important minimal invasive treatment option for trigeminal neuralgia that includes focused and spatially precise irradiation, causing some degree of gradual lesioning of the trigeminal nerve. Stereotactic radiosurgery for trigeminal neuralgia is usually performed in a single session using a frame-based approach. High-resolution MR imaging is required for precise treatment planning and usually includes T1 and T2 weighted MRI sequences. Planning using CT cysternography is rarely done for patients who are unable to undergo MRI. Dose planning is performed using a computer software, and radiation is typically delivered using a single 4mm collimator. For dose planning, it is important to consider the length of the cisternal segment of a trigeminal nerve that can affect treatment target selection along the nerve. It is also important to consider integral nerve dose, brainstem dose, prior nerve dysfunction, and prior treatments for trigeminal neuralgia. Radiation doses for treatment of trigeminal neuralgia have been studied extensively. Most centers utilize radiation doses for treatment of trigeminal neuralgia between 70 gray and 85 gray. The treatment dose is typically limited to 90 gray because higher doses are associated with increased risk of adverse radiation events. Neurovascular conflict is widely accepted as underlying cause of trigeminal neuralgia, and the presence of neurovascular conflict is often considered when choosing an optimal treatment strategy, especially when considering microvascular decompression as a treatment option. We examined the presence of neurovascular conflict for SRS treatment outcomes in a cohort of 106 patients with typical trigeminal neuralgia who underwent upfront gamma knife radiosurgery and did not have prior microvascular decompression. MRI images were evaluated for presence or absence of vessel compression, extent of compression, and radiation dose to the point of vessel contact. During a median follow-up of 31 months, almost 60% of treated patients achieved BNI pain score of 1, meaning they were pain-free and were not taking pain medication. Vessel impingement was seen in 59% of patients. However, we did not find differences in pain relief between patients with and without vascular impingement on MRI before gamma knife radiosurgery. In a cohort of patients who had vascular compression on pre-SRS brain MRI, better treatment outcomes were associated with increasing radiation dose and closer proximity of the isocenter to the site of vessel impingement. Treatment with SRS allows to achieve pain relief in the majority of trigeminal neuralgia patients. However, latency from SRS to pain relief as well as durability of pain relief should be considered. A study from the University of Virginia included 151 patients treated with gamma knife radiosurgery for trigeminal neuralgia. The majority of patients experienced typical trigeminal neuralgia. Median age of study patients was 68 years, and median time from diagnosis of trigeminal neuralgia to SRS was 72 months. Mean time from SRS to pain relief was 24 days and ranged from 1 to 180 days. 90% of treated patients experienced pain relief at 1 year after radiosurgery. However, the proportion of patients who maintained pain relief at 2 years and 3 years after the procedure was 77% and 70% respectively. 50% of treated patients were pain-free and off pain medication at 1 year after radiosurgery. However, at 5 years after radiosurgery, only 30% of patients remained pain-free and without medical management. Different locations along the affected trigeminal nerve can be targeted considering varying length of a cisternal segment of a trigeminal nerve. The usual preferred target of SRS for trigeminal neuralgia is the root entry zone or proximal area of the trigeminal nerve. Longer cisternal segments of a trigeminal nerve can allow treatment using a single isocenter with minimal to no blocking and with tolerable radiation dose to the brainstem. In our experience, more proximal targeting of a trigeminal nerve is associated with more durable pain relief. Trigeminal neuralgia is a devastating disease that can cause significant impairment of quality of life. Therefore, improvement and maintenance of quality of life is of paramount importance when managing trigeminal neuralgia patients. In a study by Pan and colleagues, 52 severely ill trigeminal neuralgia patients treated with gamma knife radiosurgery were followed every 3 months after treatment using visual analog scale, BNI pain scale, and SF-36 questionnaire that was used to assess quality of life. Median follow-up of the study patients was 54 months and at least 2 years. Treatment with gamma knife radiosurgery was associated with significant and durable improvement of BNI scores and visual analog scale. In addition to that, improvement in facial pain correlated significantly with improvement of health-related quality of life. In this cohort of patients, improvement in quality of life was seen in the majority of patients across all domains of quality of life. To this date, thousands of patients have been treated with SRS for trigeminal neuralgia, with sample sizes of individual case series often including hundreds of patients. Gamma knife is the most widely studied SRS treatment modality for trigeminal neuralgia. Other devices used for SRS treatment include cyberknife radiosurgery and linear accelerator-based systems. Mean clinical follow-up periods across studies range from 1 year to 3 years. In published series, from 22% to 73% of patients were pain-free and without pain medication at last follow-up. Some degree of trigeminal nerve dysfunction is the most common adverse event after SRS, with reported prevalence ranging from 6% to 47%. The reported rates of pain recurrence range from 14 to more than 50%. Stereotactic radiosurgery affords a reasonable rate of pain relief for patients with medical refractory trigeminal neuralgia and atypical facial pain. The latency period after SRS to pain relief is about 1 month. Repeat SRS procedures are sometimes attempted for patients who experience pain recurrence after initial pain response. Facial hypesthesias are the most common, although rare, adverse events of SRS for trigeminal neuralgia. Although microvascular decompression remains the treatment of choice of trigeminal neuralgia, but SRS should be considered as effective treatment alternative for patients who are unwilling or unable to undergo open surgical procedure. SRS is also a reasonable treatment option for patients with recurrent trigeminal neuralgia after failed previous surgical interventions.